Good morning, ladies and gentlemen. I'm Hong Ke from TAVR General Hospital, Taiwan. It's my great pleasure to have talk today. My topic is SAVR or TAVR. Choose wisely with a heart team approach. According to the APCIS guideline in 2020, the guideline make a recommendation according to the age, like the patient with severe AS and age below 65 or life expectancy is over 20 years. The SAVR is recommended for patients between the age of 65 to 80 years. SAVR or TAVR should be recommended after shared decision making. And for patients aged over 80 years, a transfemoral TAVR is recommended. However, the age is not a suitable cut-off point for all our patients. Because in the TAVR era, low-risk patients, most of those younger patients will outlive their transcatheter heart valve. So a second, even third AVR will be needed. So what's the suitable lifetime management strategy for them is the key point. According to the paper in JACC in 2021, the data is from the US Medicare database. The data indicates that the repeat TAVR has a comparable and acceptable outcome with the mortality of 6% and stroke rate 1.8% and pacemaker rate is 4.2%. The result of the repeat TAVR seems quite acceptable. However, for some patients that are not suitable for repeat TAVR and need to have a TAVR explantation, the 30-day mortality is significantly higher than the repeat TAVR patients, with 12.3%, which is because the surgeon today is not familiar with the procedure to expand the TAVR valve. So the 30-day mortality for the TAVR explantation is higher. So for our younger and those patients, lifetime management strategy is important. And the key point is the first choice of the first valve intervention. Like if you choose the mechanical valve for the first valve, then maybe this is a happy ending. The patient don't need to have any intervention in his lifetime. But if you choose the SAVR valve for the patient, then the following second valve would be the patient need to have a redo surgery. And then TAVR in valve, TAVR in SAVR, or TAVR in SAVR, or then TAVR in SAVR. If you choose the TAVR valve first, then the second valve will be TAVR explantation, then SAVR. And then you can do a TAVR in SAVR. Or the patient will have a TAVR in TAVR, then TAVR in TAVR in TAVR. However, some of the patient's anatomy or situation is not suitable for this repeat TAVR. So what's the main determinant for us to consider? So how to choose wisely for the younger and the low-risk patients? According to the article in press in Annals of Thoracic Surgery this August, the Cornell team, they proposed the lifetime management for our aortic stenosis patient, the strategy and decision-making in the current era. When considering SAVR or TAVR, life expectancy outweighs age. For a patient that has the life expectancy less than 1 year, the palliative care should be considered. If the life expectancy is between 1 to 8 years, TAVR or palliative care is needed. for the patient's expectancy over 8 years, according to the current data of the durability of our prosthesis valve, over 8 years life expectancy will encounter a second valve implantation. So SAVR or the TAVR with contingency plans for valve-involved TAVR or explantation or redo surgery should be considered. So the patient's anatomy and the lifetime estimated risk guide the type and the sequence of interventions and the surgeries. So we need to consider the patient's anatomy not only for the first valve implantation. Also, we need to consider the following procedure. If the following procedure is, the anatomy is suitable for the following procedure, like valve involved, a TAVR in TAVR, something like that. So the lifetime estimated risk should be considered. And any patients, we should keep in mind that any patients may require a second valve in their lifetime. So for us, the goal should be one lifetime sternotomy strategy. And we should make the surgery, especially if the procedure is complicated. The surgery should be performed at the age when patients are best equipped to tolerate. So if the TAVR was planned at later SAVR, when initial SAVR would require redo SAVR, like in some patients with bicuspid aortic valve or the patient with a very small annulus, then TAVR first strategy is reasonable to postpone the surgery or to test the biologic compatibility in selected patients. So high quality AVR is essential for the young patient. We need to avoid power valve insufficiency and the pacemaker implantation, and we need to keep the coronary access maintained, because along the aging procedure, more patients may need to have coronary intervention. So coronary access must be considered in our plan. And a gated CTA and the multidisciplinary valve team consultation should be obtained for all patients when considered to have biologic AVR, whether TAVR or SAVR. So in this halting approach, we need to evaluate the potential for prosthesis patient mismatch and valve-involved TAVR, and to decide if the patient needs to have aortic root re-enlargement procedure or replacement procedure. So the CTA, ECG gated CTA could provide us very valuable information. So if anatomy would preclude TAVR in TAVR or TAVR in SAVR, or the risk of post-SAVR patient mismatch is high, then when we perform SAVR, the procedure of aortic root enlargement or aortic root replacement should be considered. And if the local expertise is not available for this procedure, then patients should be referred to a comprehensive valve center for aortic root enlargement or aortic root replacement. And always keep in mind that the mechanical valve should be always an alternative when you consider you need to perform aortic root enlargement or aortic root replacement procedure for the patient with the small annulus, or if the patient is younger than 70 years and willing or able to use oral anticoagulation. So the mechanical valve should be always an alternative. Finally, a low-frame valve are favored if the TAVR explantation or valve-involved TAVR is considered in the future plan, because like the previous speaker indicated that the low-frame valves could cause less damage to our native root or even the ascending aorta. So for our younger and low-risk patient, the post-occurring choice of SAVR versus TAVR, we should consider life expectancy first. If the life expectancy is over 8 years, and anatomy should be evaluated. If it's suitable for TAVR and no other indication for surgery like CABG. And then if the patient is don't have prohibited surgical risk, then qualified lifetime estimated risk should be evaluated. And the decision of TAVR or SAVR should be guided according to the anatomy and also the patient preference. So the shared decision making with the patient and family is also important. So here I will share a case with the extreme complicated situation in a young patient that indicate the importance of tailor-made treatment plan for young and low-risk patients. This is a 69-year-old female with severe AS who has already had the first TAVR with the Medtronic Evolut in 2018. Then the structural valve dysfunction developed and severe AR with congestive heart failure occurs. Why the patient choose to have a TAVR first in his young age, at age 63, because she already has 2 times open heart surgery for previous rheumatic heart disease in 2005 and 2010. So at that time, she didn't want to have the 3rd time open heart surgery. So, and also the patient has some severe comorbidity like atrial fibrillation and also splenic infarction and renal infarction. So first, in the first TAVR, we choose the Evolut R 26 millimeter in 2018. The educated CTA showed the suitable anatomy for the first TAVR implantation, with the suitable height of coronary arteries and the suitable STJ diameter and height. This time, we also perform a very precise educated CTA to determine whether the TAVR is suitable for the patient. So the coronary height is acceptable. However, the valve to coronary distance over the RCA is borderline. The RCA opening seems too close to the neo skirt of the planned TAVR implantation. So our procedural planning is to have coronary protection for RCA. Then we will choose the low frame SAPIEN 3 heart valve with the low implantation at level of index Evolut R Note 4. Then the free adjustment for the balloon is -1 milliliter. So during the procedure, we attempt to engage RCA several times. And you can see we cannot engage to the RCA opening. Although this is performed by a very experienced cardiologist in our heart team. So then, according to the autogram during procedure, we can see that the RCA opening is the possibility of occlusion of RCA is not that high as the preoperative plan. So we will keep the very strictly low implantation and precisely implant the SAPIEN 3 to a very low implantation. So according to our plan, we make the outflow at Note 4 of previous the Medtronic valve, and we have a very good result. for this patient without any occlusion of the RCA. So for my topic today, the take-home message is that lifetime management strategy should be individually tailor-made for all the patients. And a strong multidisciplinary half-team approach with shared decision-making with patient and family is the key for lifetime management. And life expectancy and patient anatomy and the lifetime estimated risk should guide the type of interventions. And a gated CTA should be performed for the preoperative evaluation. And we should prepare our cardiac surgeons for possible arterial enlargement or arterial replacement, and also TAVR experimentation techniques for the future complicated patients. Thank you very much.